There are 1,000,000 ways to die. We just wanna talk about it. Codeheads.
Good morning, Codeheaders.
Welcome back, everyone. Very excited you're here.
Oh, and I just realized I always say good morning, and you always say good day, good afternoon, good
Well, I'll say
evening.
good morning, but then I forget our
Yeah,
listeners, they could be listening at any time and they could be in another time zone.
yeah, that's valid.
We,
A lot of
we
our
had,
listeners from different time zones.
what is it? 2 weeks ago, we had Nate from Australia writing in
Oh,
for
yeah,
Ask a
that's true.
Codehead.
So, good day to everyone.
Yeah, there we go.
Much more encompassing. Um,
Inclusive.
yes, so I'm including us all. Um, well, today we have a topic that I'm kind of excited about. I'm not sure why I'm so excited about, but we wanted to talk about EMTALA, so Emergency Medical Treatment and Labor Act, which I feel like people hear a lot about, especially in the emergency medicine world. And people talk about it, but I'm not sure that ever really understands the true nuances of EMTALA, why it was created, why we have it. So it is a federal law in the United States. So for those listeners that are not in the U.S., sorry, this might be a boring one for you, actually, after I was so inclusive of welcoming you. But it was a law that was passed federally in 1986. And it's part of our, actually, the COBRA law, the Consolidated Omnibus Budget Reconciliation Act. And so it was created as like a core purpose really to prevent patient dumping. So there was a time, obviously not too long ago, that various hospitals would refuse care or kind of inappropriately transfer patients to a different facility based on their ability or lack thereof to pay for care, or their insurance status or some other, non-medical reason. It could have been something psychosocial that they just didn't want to deal with, like someone that would need long-term care placement. And they knew that patient would be there for an extended period of time without according to them, proper insurance. So welcome a little bit into the insurance nightmare of the United States.
Yeah, patient dumping, just so everyone understands, our lay people. So we're people were being transferred mid-crisis.
Yeah,
Yeah, they were presenting in a way where they should have been dealt with immediately, and based on that criteria, which is totally unethical, but it was
correct.
standard practice at the time, they were shipped out.
Right. Yep. They would say, "Oh, sorry, they're underinsured or not insured." All right. Well, we know you're hanging by on a thread, but out you go.
Sorry.
So it was really started to kind of ensure that there was public access to emergency services, regardless of your financial status. And period. We want everyone to have access to emergency medical services, no matter what. And that does apply to any Medicare participating hospital that has an emergency department. So that's basically every emergency department within the U.S. But I do want to share a little.
Incoming fun fact.
Yeah, a little fun fact that I have for a lot of people that do not recognize about EMTALA is where it actually extends to. So everyone says, "Oh, well, it's related to emergency departments." And yes, that is absolutely true. But the EMTALA, like where it actually covers for a physical hospital that's a participant of Medicaid and Medicare, is actually 250 yards outside the physical hospital building. So it's not just outside the emergency department, it's outside any part of that hospital. And 250 yards is like 2.5 American football fields without the end zones. But
That is a lot further than I would have guessed. That is a wow. I was thinking
yeah.
50 yards around the perimeter. That is a tremendous length.
Yeah, and that includes parking lots, sidewalks, driveways,
Wow.
Yeah, and it can cover some, like, off-campus facilities too. So, that's like if you have a physical hospital location, great, but there are more hospitals that are expanding into kind of like the outpatient world and trying to bring care into communities, as opposed to having everyone, come into these large tertiary care centers in the middle of, cities. So if there's like a dedicated off-campus, standalone ED, emergency department that takes emergency care, that is part of EMTALA too. That area is covered.
Yeah.
Um, or an urgent care. Some urgent cares that do higher level urgent care responses are covered under EMTALA too. They do have to give emergency services to this patient or patients that are coming in and technically on their property. Um, and also, because a trend has been in the last few years that hospitals are either affiliating with or owning ambulances, like their own kind of like mini EMS. Um, a person, once they get into one of those hospital-owned ambulances, technically is covered under EMTALA. That
Right.
is, they have already, they're considered like they've arrived to the hospital the moment they entered that bus. So it's something to think about, because, you know, we used to be like, "Oh my gosh, the hospital is so full that, the emergency department is going on diversion. We can't possibly take another patient in our, to triage in our, waiting room because we're busting at the seams and we have nowhere to put these patients." Hospitals cannot do that anymore.
Yeah.
Um, you know, if there's some sort of, colossal thing that there's some sort of, I don't know, massive explosion in a, city where there are multiple hospitals, they have to work together to divvy up who can take how many and whatever, but still no one can go on diversion. We have to take patients. So it's kind of it's an important little nuance that a lot of people don't know about. And so, we have to think about there could be a patient in our parking lot that's within that 250
Yeah.
yards, that is struggling, or there's like a family member that's come to visit someone and they fell out of their car and hit their head and they're bleeding in our parking structure. We need to have a process to respond to that. We need to have an emergency response. We need to have emergency medical equipment to go out and to do that. Um, you know, um, Medical facilities that do not respond to emergencies, like if it's just like a PCP office or some sort of like, primary health clinic or a skilled nursing facilities, they don't necessarily, those are not part of the EMTALA like hospital property for emergency responses, or sorry, for emergency assessments. But, um, you know, we would hope that they would have an obligation to, or they would feel ethically responsible if someone became unwell to have an emergency response and to call 911 and to, get emergency responses. But, if we are in a state where our patient is within our EMTALA boundaries, um, what does that mean to us? And that means that they need, as quickly as possible, some sort of medical screening examination
Yeah.
by a qualified medical personnel. So it's either, it's triage by, a nurse, um, and, getting either an emergency medicine physician, PA, APRN to come and assess them really quickly to see what their injuries are and to see what their treatment is. And then to stabilize and treat the patient, you know, without any regard of their ability to pay.
Correct.
Um, you know, which is
It,
which is really important. And that's what you were kind of talking about earlier, is that patient dumping, is that, you know, previously it was kind of like, oh, they're good enough, and ship them off, but they can't be, you know, not
right.
stable transport and go to somewhere else.
Right. And that MSC medical screening exam has to match the complaint. So chest pain should get a different workup than, say, a sprained ankle, right?
Yes. Yep.
One of them is going to get a 12 lead, I would hope. And
Yep.
one is not, most likely, unless they're complaining of something else besides that ankle.
Yeah. No, but that's valid. It's that they're getting the medical screening evaluation for what they are coming in for a complaint of or concern for.
Okay.
Yeah, so that, yeah, and that's, and then part of that gets bumped into the internal, processes within each emergency department or urgent care or whatever place that we're talking about of how they triage and, what they do for their assessments. But they do have to have a documented, pointed assessment really quickly with a plan of care, whether it's finish this workup, they need a further workup or, they're fine. And, we are probably not going to be admitting them to the hospital or, you know, um,
That 200, I'm still stuck on that 250 yards, to be honest,
I,
because where I've worked, it's a massive hospital, massive landscape in a very urban area, tricky
yeah.
to navigate, lots of
Mhm.
structures. And I would say, and maybe it's just me, but most staff members, at least in my little department, which is non-patient facing care, just so we're clear, they do not realize that our facility isn't just our facility, right?
Oh,
We are moving, I mean, 250
well,
yards.
that's why at certain places that we've both worked together, there's, a painted line like on the street, like to
And
go and show and like on part of the sidewalk in the street to show what is like this is our hospital.
it is a
Um
line to find though in such a chaotic area,
no,
right?
it can be, but that's why patients that are down on the sidewalk, like there's been many times that we've responded out to a sidewalk or, you
Yeah.
know, a car that is like, eek, like kind of pulled up on the curb and they're like, oh, something's happening. Like we've responded.
And you
Um,
know a lot about those lines, right? You were directly involved with some of this where you worked.
yes, I was. Um, but then
Yeah.
I've gone to other, but I've worked at other places or gone, when, to help out with other hospitals and they're like, oh, what? And they don't, necessarily recognize like I'm not saying that not everyone recognized, but um, staff members certainly had no clue that they were obligated to respond. And I'm like, oh, nope, they're on our property. We gotta do this. Because every EMTALA violation, like first of all, I do think that, patients or family members like definitely they don't know about that 250-yard rule.
No.
Um, but we should, as providers and anyone giving emergency medical treatment, should know that, and even our staff should know that are just any staff that work within the hospital because they should know
Totally.
what we have to respond to, and what we should be responding to. And I would hope that if they're a caregiver and they're walking over someone on a sidewalk that's needing help, that they
Right.
actually are
And
like, oh, I
and
have to clock in. They stop and they actually help them. But
and
um,
outside of ethics, there are major financial consequences for the facility if they don't follow EMTALA.
correct. Yeah.
Severe
So it's,
potential to
yeah.
just you,
Yeah.
you
It
know.
can be at a minimum $133,000 just per complaint per violation.
I mean, yeah, and there's a threat that you could lose. I mean, the threat that you could lose Medicare participation entirely, which would virtually be a death sentence.
Yeah, because if they're I mean, it's
So-
not easy to run a hospital, but not getting any sort of Medicare or
Right,
Medicaid
right. I
reimbursement,
mean,
yikes, you're in
financial incentive is important. Just to remind you, I mean, ethically,
right,
yes, we shouldn't even have to think twice, right? We
right,
shouldn't be stepping over someone. We shouldn't be like, oh, they're on the sidewalk. I got to go, but I work here.
right.
It's like, but a nice little financial incentive push never hurts.
Agreed. Yeah, and so if you get multiple complaints or violations, yeah, it's not just like I think that's why I'm saying a minimum of 133,000 because it starts going up. So if you have multiple violations, that's it starts really adding up, and the cost goes up, and you could lose, yeah, CMS licensure, which is a big, huge deal, and no one wants to do that. Yeah, it's just not a good idea. Um, and there's one other kind of thing is that sometimes there are times that, we have patients that are in hospital that maybe the family wants to go to a different hospital. So the patient and family member are like, oh, we're at XYZ hospital because this is where the ambulance brought me during my emergency, but I want to be there, at another hospital closer to home. Um, you know, there are processes now at all hospitals to be able to do that. But to be able to maintain those EMTALA rules, it really has to have, there are just different criteria. You have to have a provider call in and make that referral to the hospital. that they want to transfer to. And then they have to have a provider on their end that says, yes, I'm willing to accept this patient. They are stable for transfer. They kind of do like a teletriage of that patient and then accept to be able to bring them in. But if there's any change in that patient's presentation, like if they get a lot sicker or whatever, like as I said before, kind of like patient dumping, if they change how well or unwell they are in the time that they're supposed to be transferring facilities, um, you really you can't. They need to be like healthy and well. Um,
as they should.
well, correct, yeah. So it is really important, and it's something to think about. And I do think that most people use the verbiage of EMTALA, and there's a lot more nuances that go into EMTALA. But I think we wanted to kind of really point out the fact that, for lay people, you do have protection. You are protected to be able to go to any hospital, any place for emergency services. It doesn't matter, what your status is. It doesn't matter how much money you have. It doesn't matter if you are insured or not insured or whatever. You can always figure it out with the hospital afterwards. We want everybody to be able to seek care and not stay at home and be afraid of that. The flip side is if you have something that is not emergency care, you don't always have to go to an emergency room. There are urgent cares. I know it's difficult to always get into a PCP, but there's cheap options for telehealth too. If you can't get into a PCP, if you're worried about going to an urgent care, if it's really something that's not an emergency, and it's something that's been bugging you for a few weeks, like a little cough or something, that's not something you want to necessarily run into the ED with, because hospitals can't go on diversion and people are sicker. Hospitals are busting at the seams with patients,
Yeah.
and the EDs in particular are the ones that take the hit there, because
And
literally
EMS.
keep coming. Yeah, and EMS. And, the patients keep coming, but, there's only so many beds, only so many rooms at the inn. And we want to make sure that everyone gets the right place in the right amount of time, and gets the best care that they can. So we won't say no. We will, always welcome with open arms. And for the healthcare providers in there, just make sure that wherever you work, that you guys know where your hospital physically ends as according to EMTALA, and make sure that you have policies and everything in place to be able to take care of those patients that might not fully make it to the door. What do you think about that, Mike? You got any thoughts? Any
I do.
closing
I'm going
wisdom?
to save them for a later episode because I just had a new idea for another
Oh,
episode where you said welcoming everyone with open arms, and we're talking about maybe staying or way to go into other alternatives to the ED. I think we could really have a whole topic on that
well,
because
that's valid.
urgent care is in pretty much every strip mall now. And I don't recall
That's
them
true.
being around
Yep.
15 years ago, but they're everywhere and they
Mhm.
are wonderful. And it's a great option to have sort of one step before going right to the emergency room, right? Giving you one, and they're connected to the emergency rooms. They're connected with these facilities. They communicate, right? They're not
Right. Yep.
just unique and alone. Like they are part of the system. At least the ones around me are all part of these
Yep.
hospitals around me.
Yep.
So you have continuity of care. And it's just, yeah. So I was saying, that's what I mean. I could do another 10 minutes and I don't want to do that to our listeners on options, on reasons why maybe you could go to other locations
That's
outside
bad. Yeah.
ED. Not to discourage people that are in acute distress. I would never do that. But
Correct.
anyway, so that's what I have to say if you're asking me, but we could save
All
it.
right. Well, I am asking you, but that's all right. Well, we hope that you guys found this enlightening and helpful. And this was actually a question from someone had written in with asking more about Entala. So I hope this helps and we answered your questions. And
I cite who asked the question because people like to know where our listeners are. So we had
well,
Australia last time. This one's not as interesting because it's near us, but it was Martin from Connecticut.
oh, Martin and
Mhm.
near me. All right. Well, we appreciate all of you guys listening. Continue to, reach out and touch us. And we will talk to you soon. You'll hear from us before you know it.
We
There are 1,000,000 ways to die. We just wanna talk